Good afternoon, everyone. Please know that we are recording these sessions for later distribution through the Chagas Echo website. We are excited to have you all join us today for the Chagas Echo series. This session is brought to you by the Rockefeller University, Clinical Directors Network, Texas State University, San Diego State University, and UT Health San Antonio Echo. I'm Kato, and I am with the UT Health San Antonio Echo Super Hub. I just have a couple housekeeping announcements before I pass things over to Dr. Stigler Granados to continue with the introductions. Next slide. Here's our agenda for today. We'll start off with some introductions and announcements, then move on to presentations from our speakers with time for Q&A at the end. During the session, please stay muted unless you're speaking, but we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu to raise your hand, or you can use the chat to ask questions, answer questions, and share any perspectives you may have anytime during the session. And please note that no protected health information is allowed in either the chat or our discussions. Next slide. Thank you. The topic of discussion today is working with public health agencies to better understand reporting in clinician education. This is the first session of the 4-part series. We will be offering continuing education credits for providers and nurses at 1.5 hours CME CNE credits for each session. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it out to receive free CME or CNE credits. And next slide. And for those who may be new to ECHO, it stands for Extension for Community Healthcare Outcomes. This is a model of lifelong learning and guided practice that connects community-based health workers with each other and a multidisciplinary team of subject matter experts to create a community of practice and learning. The ECHO model rests on these 4 key principles: technology to leverage resources and create knowledge networks, improving outcomes by sharing and standardizing best practices. And the heart of ECHO is this case-based learning concept. We are all learners and all teachers in this space. This is a space for you to share your own challenges, strategies, resources, and lessons learned with your peers and colleagues. With that, I'm going to pass the mic over to Dr. Stigler Granados. And next slide.
Good morning, everybody. Thanks for joining us. Almost probably afternoon for a few of you on the call. Happy to be here today. I'm starting up another series now on Chagas with our echoes, and I'm happy to partner again with our Clinical Directors Network for this one. If you all are first time coming, welcome. If you've been to our previous sessions, thanks for coming back. So as you just heard, we do have CMEs for this. This is funded by our CDC cooperative agreement that we have for raising awareness on Chagas disease and educating healthcare providers. And it's also from the CDN side, it is funded by the SNF Institute of Global Infectious Diseases Research, as well as the Rockefeller University. And there's, I'm sorry, Maria, if you're on, help me out here. I don't see it on here.
Stavros Niarchos Foundation.
Thank you so much. It's probably on the next slide. Thank you. Next slide. So just a little bit about the Clinical Directors Network. Like I said, we're super excited to partner with them again. They're a New York City-based practice-based research network with an AHRQ designated Center of Excellence for practice-based research. And they are dedicated to improving access to care and clinical outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, training, and service. Next slide, please. This is just a model that they have for building community academic with translational research partnerships. And you can take a look at this. I don't think I'm gonna go over the whole thing, but this is how the infrastructure works with the different infrastructure of how they have things set up. Next slide. And again, we're calling this our educational series 2 because we had one last year, and we are going to have 4 parts to this. Today's the first one. If you signed up for this one, then you're automatically signed up for the next 3 after this. So we hope that you can join us again February 14th, so Valentine's Day. which seems appropriate, talking about Chagas disease and kissing bugs and heart disease. But we'll have how to screen, diagnose, and treat Chagas at FQHCs, as well as another one on global to local. And then the last one will be about Chagas disease among people living with HIV and other immunocompromised groups. Next slide. So I'm excited to introduce our presenters. Some of my favorite people in the whole world are talking today, who I've had the honor of working with almost for the last decade. So I'm going to go ahead and just give a brief bio for all of our presenters, so that way once we're ready to get started, we don't have to stop and reintroduce. They'll be ready to go. Dr. Sue Montgomery, who I'm very excited to have with us. She is an epidemiologist at the CDC. And she coordinates all activities related to Chagas disease and other neglected parasitic diseases in the US. She received her DVM degree from Cornell and MPH from Harvard School of Public Health. And it's an honor to have her with us talking about and sharing all of her knowledge on Chagas disease. She is absolutely the go-to person in the United States for this. So thank you, Sue, for being here. We've also got Bonnie Mays, who is in Texas, and she received her master's degree from Texas State University, which I was proud to work there for several years. She's worked as a microbiologist, adjunct biology professor, molecular epidemiologist. She currently works as a zoonotic disease epi, working primarily with Chagas disease and all the reportable tick-borne diseases, leishmaniasis, flea-borne typhus, and rabies. She has multiple publications in peer-reviewed journals and books, primarily on rabies, diagnostics, bat and skunk rabies, and flea-borne typhus. She's also co-chair of the James Steele Conference on Diseases in Nature Transmissible to Man, and is also a registered yoga teacher. So thanks, Bonnie, for being here. She is the Chagas go-to person and rabies person in Texas. So we're happy to have you. And if any of you have ever attended the Diseases in Nature conference, if you haven't, I would highly recommend it, and she can probably give you more info on that. And then we also have Dr. Aislinn Vaughn, and she is a CDC Epidemic Intelligence Service Officer assigned to the Los Angeles County Department of Health. Prior to the EIS program, she spent the last 4 years working on world health emergencies at the World Health Organization, including COVID-19 and impacts global responses. She's also had a lot of experience in academia, from malaria vaccine research, arbovirus epi, and avian influenza research during her PhD at Imperial College in London. Her interests include emerging and zoonotic infections, emergency response, and global health. And outside of work, she loves hiking and ceramics. So happy to have all three of our speakers here. Again, we're talking about public health agencies, and so this is going to be coming from the federal, the state, and the local perspective. Next slide. Oh, a little bit about me. If I haven't met you before, my name is Dr. Paula Stigler-Granados. I am with the School of Public Health in the San Diego State University. I'm also the division head of our environmental health division. I'm also the PI on our CDC funded cooperative agreement to provide education and awareness for healthcare providers on Chagas disease, and I've been doing that since 2015. We also have our, what used to be the Texas Chagas Task Force, we now call it the US Chagas Task Force, and just love to talk about all things related to Chagas disease. So thank you all for being here. I'm happy that you were able to join us, and I think that we will probably go ahead and get started. Is there one more slide? Oh, this is just a little bit of the reminders I think that Cato already covered. Before you leave, make sure there's going to be a evaluation link in the chat. Make sure you get that so that you can fill out the evaluation. You'll also get an email receiving it as well. We are recording these sessions, so we will have them to watch again or to share with colleagues. And please use the chat for asking questions, and then we'll also have some time for Q&A if you want to speak as well. But feel free to start putting your questions in the chat if they come up, and we'll do our best to respond. And my job will be to help facilitate those questions with our speakers as well. Okay, that was a lot. I think that we are going to turn it over to Dr. Montgomery first. And while we pull up her slides, just a reminder in the chat, please let us know where you're coming in from. And I think we're ready to go.
Okay, great. And this is a sound check. You can hear me?
We can hear you great. Thank
Okay,
you.
terrific. Next slide, please. I'm going to start with just an introduction to Chagas disease so that everyone is aware of the basics of this disease and who it affects and how you get it. Chagas disease is caused by a protozoan parasite called Trypanosoma cruzi, which is only found in the Americas. It is vector-borne, and there are many animal reservoirs, and animals actually are mammals. So warm-blooded mammals are the ones that can become infected. Transmission is primarily by triatomine bugs, and it's not the bite of the bug. These are blood-sucking insects, but it's actually the feces. So the triatomine drinks blood. The parasite is found in the gut of the triatomine and passed in their feces. And that's how it enters the body through a break in the skin or the conjunctiva. Congenital transmission is also possible from an infected mom to her baby in utero through blood transfusion, organ transplant, tissue transplantation. Rarely there are lab accident infections where people working with the parasite or the vector bugs can become infected, and foodborne, which is a growing concern in parts of South America in particular, where people are eating foods that are not pasteurized or cooked and are contaminated by the triatomine bugs. About 5 to 7 million people in Latin America have Chagas disease, and in about 30% of those infected people, cardiac and or gastrointestinal manifestations can develop. Next slide, please. This is the life cycle of the parasite, just to illustrate a few key points. On the left side, you see the triatomine part of the life cycle. And as I said, they take a blood meal. The parasite is drawn up in the blood of an infected host, mammal or person. It multiplies in the triatomine in their gut. When it goes to feed on another animal or a person, it often defecates at the time it's feeding or shortly after. And that bug feces is where the parasite is found and can be rubbed into the bite wound or the patient's eye, and the parasite enters the body that way. Once it's in the body, I'm on the right side of the life cycle now, it is in the blood. It will go to tissues and penetrate cells where it multiplies in a form called a mastigotes inside the cells. Every now and then one of those cells will burst and release the parasite back into the blood, where it will transiently be found at very low levels during chronic infection. And because of that, the blood being drunk by the next triatomine may contain the parasite that completes the life cycle. Next slide, please. This diagram illustrates the way Chagas disease develops in a person, an infected person. So infection occurs, the first 8 weeks are the acute phase of the infection, where the parasite is found in the blood. The illustration, the picture on the upper right corner is a trypomastigote in a blood smear. After those first 2 months, the infection transitions into chronic phase. The parasite is not found in the blood anymore, it's in tissues. And the picture on the right below the blood smear is a nest of amastigotes within a muscle cell. During chronic phase, people are asymptomatic. They're in what's called the indeterminate form, and that can last years to decades, after which about 30%, 20 to 30% of those chronically infected will develop cardiac or gastrointestinal manifestations. But about 70 to 80% of infected people remain asymptomatic throughout their lives. However, they could be a source of transmission if they donate blood and the blood is not screened. They could be a source of transmission if they're a woman and they have a baby that becomes congenitally infected, and they're always at risk for reactivating their infection if they become immunosuppressed at some point. Next slide, please. So who's at risk for Chagas disease in the US? Now I'm going to transition into the picture in the US and what is the background for what public health surveillance needs there may be. Most of the people in the US with Chagas disease acquire the infection in the endemic areas of Latin America. That's Mexico, Central America, and South America. And the Caribbean islands Chagas disease is not transmitted on the Caribbean islands. And we estimate about 300,000 people in the US acquired Chagas disease in Latin America and are living here now. You can also acquire the infection in the US. Not that many cases have been documented. That's probably tip of the iceberg. There are probably a lot more, but it's really fewer than 200 so far. And that includes people who are exposed to triatamines in the US, where the parasite is transmitted in wildlife and triatamines. Children born to infected moms, mothers in particular who come from parts of Latin America and are chronically infected. We have had cases of donor-derived infection in people who receive an organ transplant from an infected donor. And before blood screening was introduced in 2007, there were people who acquired the infection through blood transfusion. And we've had a couple of laboratory workers who acquired infection too. Next slide, please. Just to understand where people who are coming to the US might be at risk for Chagas disease, this map shows you places where the disease is endemic. And it's really pretty much all of Latin America, excluding the Caribbean, but not the very far south in Argentina and Chile, because it's too cold for the triatamines down there. And then there are parts of the countries even further north where transmission hasn't occurred, either because the conditions aren't right for the triatamines, or there aren't that many people there, or other reasons. But this map shows you that it's pretty much everywhere in Latin America. And we have many people from these areas who are now living in the US. Next, please. So I'd said that we have triatamines in the US, and we do. We have 11 species of them, and they're illustrated at the bottom here. And they're found pretty much everywhere you look south of the 40th parallel. They are sylvatic. They're living in wild, forests or brush. They are feeding on wildlife, animals like wood rats, possum, raccoons. And triatamines were first reported in the United States back in the 1800s. So this is not a case where they are moving north because of climate change, or they are being, introduced through transportation in trucks or something from Latin America. They have been here for at least 200 years. Next slide, please. So now I'm going to switch to describe what public health surveillance really means, to sort of set a background on what happens in public health. Why do we conduct public health surveillance, and how is it set up? So as a definition for public health surveillance, the continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice. So public health practice would include disease prevention efforts, things like health education or mosquito control. Those are all activities around public health practice that are preventing and controlling disease. And why and how does a disease become reportable in a state? So in most situations, and you'll hear more about this from Bonnie, a state decides to collect cases of reports of a disease because there's a public health action needed. So for example, cases of E. coli infection, and the state will want to track those outbreaks and figure out where the infection is coming from so that they can do something about preventing those infections, taking that food item off the shelf, for example. And then there's also, if there's a concern for introduction of a new or exotic disease, so something like Zika virus, or back in 1999 when West Nile virus first showed up in the United States, those diseases were made reportable by states where they were occurring because it was new, and they wanted to track the spread and understand who was at risk and what measures needed to be taken to prevent the spread and control it. Then there are also conditions that may be unusual. So it's E. coli, and that responds to the regular antibiotics, but suddenly people are becoming infected with E. coli and they're not responding to the antibiotics because there's a new antibiotic resistance, and they will want to conduct surveillance to capture the specifics around those cases and potentially culture and test the isolates from those cases as well to understand that resistance. So depending on the jurisdiction, and it varies state by state, a state may actually have to take legal action to add a disease to their list of reportable conditions. Some states don't have to go through their legislature, but others do. Once it's reportable in a state, there is a legal requirement for providers, healthcare providers, and labs that are performing testing for that disease to report positives or patients who are infected to the state. So when I talk about national surveillance, this is an important distinction to make, that it will be legally required at the state level for providers to report to the state, but we don't have a legal requirement for states to report nationally. Next slide, please. So at the national level, most of our public health surveillance is through the nationally notifiable diseases surveillance system. And it's a partnership with the 50 states and several local and territorial health departments. Nationally notifiable conditions started with only 15 back in 1912, but we are up to 120 as of 2023. So that's a lot of diseases for each jurisdiction to potentially keep track of, and not all of them are reportable in every state. So states decide which they want to make reportable in their jurisdiction and which they don't feel are important for their population. How does a disease become nationally notifiable? Usually it's already reportable or notifiable in quite a few states. Often almost 50% of them will already have it be reportable in their jurisdiction. So the idea of making it nationally notifiable makes sense, because you want to have an understanding of what the burden is nationally, not just in the state. What are states next to you seeing as well? So again, they want to track the cases consistently. They want to have a common case definition so that a confirmed case in one area is the same criteria have been met as a confirmed case in another area. And the process involves creating that case definition, a surveillance case definition, in collaboration with subject matter experts, which are typically found at CDC or even academia. Sometimes are brought in to work on them. But the definition is drafted by those state and local health departments first. The case definitions are then presented at the annual meeting of the Council of State and Territorial Epidemiologists, happens once this year, usually in June. And they discuss and revise and hopefully eventually will approve that case definition. And if it is deemed appropriate, then the Council of State and Territorial Epidemiologists voting members can approve it as a nationally notifiable disease. Next slide, please. So how do we go about even finding a case that gets reported, whether it's to the state or then eventually to CDC? And this is where it's important to understand what the barriers can be. So a person becomes ill, they have a sickness, they have symptoms, they seek healthcare, and their healthcare provider diagnoses the cause of their illness. So if someone has a diarrheal infection and they go to see their doctor, the doctor would then diagnose the cause of their illness. It's characterized by typical signs and symptoms, but it also involves laboratory testing in most situations, so that we have a confidence that this is truly what is causing the illness that the person is presenting with. If the condition is reportable in that state, then the healthcare provider or the laboratory that performed the diagnostic testing report the case to the state public health department. And then the state health department will conduct a case investigation where they collect information to understand whether this case is confirmed or probable or a suspect case. There are different criteria for different levels of confidence in the case, whether you are 100% sure that it truly is a case of E. coli or not, because of the criteria in that case definition. And if it's also nationally notifiable, then the state will report to CDC. So first, the patient has to seek care from a healthcare provider. A lot of people don't, and their diarrhea eventually goes away. Or if they're Chagas disease, they may not even have any symptoms and they don't see a healthcare provider for that anyway. The healthcare provider has to think about what disease this could be and ask for the appropriate testing. For Chagas disease, that healthcare provider has to be sensitized and aware of Chagas disease and think, my patient could be at risk for Chagas, so I need to ask for, request the appropriate testing. if the condition is reportable in the state, then the patient's diagnostic confirmation or presentation gets reported to the state. For Chagas disease, because it's usually laboratory testing that defines the case, not symptoms, that key step of testing is really critical for identifying a case and bringing it to the attention of public health. Next slide, please. So the current situation with public health surveillance for Chagas disease is that it is reportable in 8 states, Arizona, Arkansas, Louisiana, Mississippi, Tennessee, Texas, Utah, Washington, and 2 counties, Los Angeles County and San Diego County. And we did write a case definition for surveillance with the epidemiologists in those states for 3 forms of Chagas disease: acute, chronic, and congenital. And those case definitions were reviewed and approved by CSTE this past summer. It doesn't mean that Chagas disease is now a nationally notifiable condition. It means that states are using the same case definition to categorize and collect information about cases, and they can voluntarily share those case counts with CDC since we have that approved case definition from CSTE. So you notice that most of the states where Chagas disease is reportable are in the southern half of the country, and that's because they're very concerned about a public health response needed for locally acquired infection, so potentially triadenine exposures, or for Washington state, as well as those states, the concern for possible congenital transmission from a mother who has chronic Chagas in that state. Next slide, please. And I think that might be my last. It is. All right. And I'm happy to turn. We want to do questions at the end, Paula, or?
Maybe we could take like 1 or 2 questions if any pop up right now, and then we'll move on. Does anybody have any questions for Dr. Montgomery before we move on to Bonnie? Okay, if you think of something, put it in the chat. Janet says, does anyone clear the triadenines? Janet, what do you mean by clear? You mean test?
So, so instead of being in this kind of non-committal state, does anybody ever recover and just not have triadenines anywhere?
I think she means the parasite. So in other words, do they ever clear the parasite?
Right, I meant the parasite.
That's okay. Yeah.
There is not any good, strong evidence to show that people clear the infection. There are some groups in South America that feel that they are seeing people who've cleared the infection, but one of the problems is the limitations of diagnostic testing and the ways that they monitor infection in someone who's chronically infected. So in short, maybe, but unlikely.
Thanks. Any other questions?
Hi, Sue, it's Nancy Jenks. Why do you think the Caribbean is protected from triadenine bugs? Just because it's...
So there are triadenines on the Caribbean islands, but the parasite isn't found there. And, there are different theories about the evolution of the trypanosome. So they're probably related to, the African trypanosomes that are circulating in sub-Saharan Africa. And maybe evolutionarily, they came to this series of continents many, many, many years ago, and they've evolved. And for whatever reason, the parasite has not been found on the Caribbean islands. They are apparently isolated.
Interesting. Thanks.
So we have a quick question in the chat. Is there any data for CDC to return and offer confirmation of Chagas cases? If not, does someone in California or Northern California know where to send a test for confirmation?
Oh, is this a question about the diagnostic laboratory at CDC?
Oh yeah, sorry. I think it is.
Okay. So our Chagas disease serology is currently paused, But if you reach out to us, and you can reach out to me, Salvador, and I'm happy to talk to you about what options there may be to go about confirming patients now. Hopefully our testing will be back online soon.
Hi, this is Neida. I joined a little late. Thank you for the presentation. I have a question. I'm not sure if that was covered, but I'm calling from New York. So with a lot of immigration or immigrants that we are seeing from South America with potentially, carrying the parasite, would you consider screening of Chagas important? And maybe I don't know how many people will eventually continue coming and to live here. Maybe consider the state to include Chagas in the screenings, and to be one and another state that reports to CDC, and what the steps or would be needed for that.
So I think the next ECHO session is about patient screening and setting up screening programs and things like that. Yes, we very much want to encourage healthcare providers to think about Chagas disease in patients who might be at risk for it, because even if they're asymptomatic but chronically infected, it's important to get them into treatment as soon as possible, and also to consider, especially if they're women of childbearing age, that they may be at risk for passing to their children. The issue about making a disease reportable for public health surveillance, I covered, I hope, with some detail, but it involves a perception from the jurisdiction, the state, that making it reportable and going through all the work that's required to capture case reports and investigate them and track them leads to a public health action that has implications for disease control and prevention. So it would be up to the state to look at their specific situation and decide whether this was a good use of resources for them. As I had said, it's not nationally notifiable at this point. There's only 8 states where it's even reportable. So our understanding of the burden of Chagas disease in the United States is really based on those estimates. And even if it was reportable or nationally notifiable, we would only be hearing about cases who are diagnosed by a healthcare provider who knew to think about Chagas disease in their patients. So that's the barrier that we are focusing on and working with Paula on, is to increase provider awareness so that those people's infections are being identified, so that screening is being done.
Thank you very much.
Thank you. And Sue, thanks for responding to those questions. And yeah, our next couple of sessions, we are going to talk about screenings and who to screen and when and how. So if you're able to join the next session in February, on February 14th, that would be great. And I think we actually have, just trying to think who is on that next session. I think we have Dr. Chris Coyle from Einstein up in New York talking about screening immigrants in New York. And so that would be a really great time, and talking about FQHCs. If again, for some reason you're not able to join NADA next time, we do record the sessions, and so we'll have those available to you. But really good questions. I'm gonna go ahead and introduce Bonnie and have her go ahead and talk about what it's like from the state perspective. And I want to just say, like, with Bonnie, her and I met back in 2015 when I first got this CDC grant. And I've always felt that, of course, being from Texas, I guess I have to say that to get that out there, but originally from there, I feel like Texas has really done a lot of work leading the way in how to do surveillance. And so thank you, Bonnie, for also helping to lead that case definition for the CST statement that was done. So a lot of work going on, and we're happy to have you talking about the work that you're doing there and the story of how it came to be. So thank you.
Thank you, Paula and Sue. And I just want to let you know, my camera's here and then I've got, because it's on my laptop. So if I am looking away, that's the reason. All right, you can advance. All right, so today I'll be covering kind of when and how Chagas disease did become reportable in Texas, a little bit about our Chagas disease cases that we have reported since it became reportable. Also, we have been doing vector surveillance for a little bit longer than the human surveillance. And we did have animal Chagas disease reportable for a few years. So I'll be sharing all of that data with you. In addition, we have a lot of Chagas disease resources online, because when you make Chagas disease reportable in your state and when you've got a lot of bugs, you're going to get a lot of questions. So easiest thing to do was to put a lot of the answers to those questions and resources online. And then lastly, I'm going to discuss some of the Chagas disease challenges. Next slide. And you can go ahead and go to the next one. All right, so reporting in Texas. So the effort actually began whenever, before I was working with Chagas disease. So it was a previous epidemiologist that took those first steps to make it notifiable. And some of the justifications that were given for adding this to the TAC, or the Texas Administrative Code, was number one, Chagas disease is endemic in Mexico, including the border states. And of course, we share a border with Mexico. Testing of blood donors in the US suggests that Chagas disease transmission is occurring in the southwestern US. Also, our surveillance indicates the presence of the organism, the competent vectors, and also positive wildlife reservoirs. And then, of course, there is a need for more public education on Chagas disease as a public health threat, and a need to increase healthcare provider awareness of the disease. And so, to sum it up, so the paragraph there, adding Chagas disease will allow state and local public health agencies to better characterize the scope of the disease in our state, to increase awareness in both the general public and healthcare providers, and to identify public health risks posed by the human carriers and identify methods of risk reduction. And so it was in 2013 when both Chagas disease in humans and animals became reportable. You can go ahead and go to the next slide. And this just gives a kind of a snapshot of Chagas disease in Texas from 2013 to 2023. The first thing you'll see there, the counties that have the red border, those are where we have identified locally acquired human cases. Now, I do want to specify that for the human cases, some of these are acute cases, and we know specifically what county these were acquired in. However, most of these are chronic cases. And so while it was determined that the person acquired the disease in Texas, it's not necessarily in the county that you see in red. Secondly, Chagas disease was reported in over 400 mammals, and we did stop reporting in animals after a few years, because it was, it did take a bit of time, and we had all kinds of things happen, like such as Zika and stuff like that. And so we had to put resources into that, but I will share that data with you in a moment. It was very interesting. And then we have been, we've had a kissing bug testing program in coordination with CDC. CDC does all the testing since I think 2012, actually. And pretty consistently every year we find that between 50 and 54% of those bugs do test positive for the parasite. You can go ahead and go to the next slide. The human Chagas disease cases, I will share a little bit of information there with you. go ahead and go to the next slide. All right. So when before Chagas disease actually became reportable in Texas, I wasn't involved in the initial case definition development, but we started with 3 different case definitions. There was acute Chagas disease, chronic indeterminate or asymptomatic Chagas disease, and then chronic symptomatic Chagas disease. And these are the case definitions that we, or at least the categories that we used up until the end of 2024. We started with these as very sensitive so that we could cast a wide net. And then over the years, you know, as we learned which of these cases are more likely to be confirmed as true cases, the case definitions became much more specific. And so now, as Sue mentioned, we did develop a national case definition, which we are going to start using for 2025. And that includes just one category of chronic Chagas disease, and then acute Chagas disease and congenital Chagas disease. Looking at our Texas data, from 2013 to 2023, we reported 273 cases. 51 were deemed to be acquired, either known with certain that they were acquired in Texas or determined to be most likely acquired in Texas. Like I said, the chronic cases, it's a little tricky to know exactly where those were acquired. 133 cases were imported, and most of these were El Salvador was the highest number, followed by Mexico and then Honduras. And then 89 were unknown. A lot of these individuals, whenever investigators tried to interview them, they don't necessarily want to share information. So a lot of these are unknown. And then case classification, to break it down, we had, during these years, we reported 4 acute cases. 3 of those were acquired in Texas, 2 in Central Texas, and 1 in South Texas. In 2024, we actually had an additional case in an infant. It was in deep South Texas. And then let's see, we had 207 chronic indeterminate and then 62 chronic symptomatic. And then I was just going to break that down a little bit more specifically. So for the locally acquired, 36 of these were confirmed. So the 3, as Sue was mentioning, there's confirmed, there's probable, and there's suspect. And so confirmed is where you are, you know, have high confidence that this is a true case. So 36 confirmed, that means 3 acute, 30 indeterminate, and 3 symptomatic were actually confirmed, and there were 15 probable. And you can, and I did want to mention these pictures. I wanted to thank Dr. Kristen Mondi from Dale Medical School in Austin. This is a photo she provided. This was one of our acute cases that was acquired in Central Texas. So you can see the Romagna sign there. And then Dr. Tyler from Region 11 provided this picture, which is a Shigoma, one of the patient from South Texas. Next slide, please. All right, a little bit about our vector surveillance. You can go ahead and go to the next slide. Thank you. All right, so as mentioned, we have been offering a triadenine testing service since about 2012, and CDC does this testing for us free of charge. And so individuals, Texas residents, and we've also accepted bugs from out-of-state residents if their state does not offer it as a service. So we'll occasionally accept bugs from out of Texas. We send those to CDC, and then they test for the presence of the parasite. And in addition, I think they started in 2015. They added a an additional test for the positive bugs to see if there was evidence of human blood meal. And I put this picture up here just to show you how similar some of the other bugs look, typically assassin bugs, to kissing bugs. You can see some of the same marks along the abdomen on the bug on the left, and then a kissing bug on the right. And so these are actually in different subfamilies. And then you can see the proboscis, so that sharp little feeding tube. You can see that there's actually a curve and a pretty thick proboscis on the assassin bug, because this is used to feed on insects versus the thinner, straight proboscis that kissing bugs use. And so I get a lot of emails, phone calls from people saying, oh, a bug attacked me and it bit me and it was so painful. And if you hear that, you know, it's likely to be an assassin bug, not a kissing bug. Kissing bugs are sneaky. The bite is typically painless, and they often kiss, feed on the victim when they are asleep. You can go to the next slide. All right, between 2013, like I mentioned, this did start in 2012, but we have incomplete data from that year. So I just started with 2013. Between 2013 and 2023, notice that Texas has a lot of kissing bugs and a lot of different species. The primary species that we received for testing was for Steckeri, followed by Sanguisuga, and then Lecticularia. As mentioned before, during these years, 54% of these bugs did test positive, and blood meal analysis during the years that was done, 35% of the positive bugs did test positive for human blood. And you can go ahead and go to the next slide. Okay, great. And then this just gives you a little bit more information. So the percent positive for T. cruzi. So as far as the stage, 60% of the adult bugs that we received tested positive versus 15% of nymphs, which makes sense. You know, adults have been around for a longer period of time, so they're more likely to be infected. Break it down by species, there's quite a bit of variability here. 60% of Gersteckeri, 71% of Lecticularia. We didn't receive a whole lot of bugs when it comes to the Protracta and some of the other species here. So how meaningful these positivity rates are, I'm not really sure. I mean, this is passive surveillance, and we have low numbers of bugs for some. And this map, I'd like to thank Pat Hunt for pulling this map together quickly for me. This shows the numbers of positives per county in our state. So you can see that Central Texas is a super hot spot here. So kind of that hill country region. And I believe that's dark blue is, I think that's the county I live in. Yeah, sure is. And I think Austin is right here in the center. All right, you can go to the next slide. And the next. All right, so our positive animals, as mentioned previously a couple times, we only have a few years worth of data here. 439 cases were reported. Most of these cases were dogs. I think there was testing of a lot of military dogs, and that's one reason for that. Dogs have a tendency to eat the bugs, and you can get Chagas disease by eating infected bugs. So that's probably one reason for the large number of cases seen in dogs. There were also 2 cats, 1 horse, 1 rat, 3 chimps, and surprisingly, a walrus. And yes, unfortunately, we did have to discontinue gathering this data in 2016. I I'm really interested in, you know, what this map would look like if we were able to, continue to gather that data over the subsequent years. Next slide, please. Yeah, thank you. I mentioned previously, whenever Chagas disease became reportable in 2013, I was receiving probably, 3 phone calls every day, people asking some of the same questions, a lot of emails, all that kind of stuff. So me and one of my coworkers quickly put together, a bunch of resources to share online so that we could provide this information to our regional offices, our state health departments. So, just easier to have all that information out there, and I try my best to keep it updated because things do change. And so we've got data, the kissing bug submission information about the disease and how it's transmitted, kind of healthcare provider specific information, blood donor testing, information about infection in pets, and ways to prevent Chagas disease, and some resources. And I did want to point out that picture on the right. I was just looking for a picture to put on here, and I found this one and thought it was really interesting. There's a video you can watch, and it's called How a Kissing Bug Becomes a Balloon Full of Your Blood. So I do suggest you check that out. Next slide, please. Okay, I do not expect you to actually be able to read all of this on your computer right now. I'm going to break it down into the different processes, but this is basically it's called a exposure assessment and testing guidance. And so it has different situations and which process, should be followed depending upon what situation it is. And so I'll just ask you to go ahead and go to the next slide. I've got them enlarged so that you can see it a little bit better. So process 1 has to do with basically kissing bug exposure. And as I mentioned before, a lot of these bugs, a lot of other bugs look very similar to kissing bugs. And so we do recommend that if a person is exposed to a bug and they have the bug, or at least a photo of the bug, that they send us a picture. They can either send a picture to us or to Texas A&M University. There's a research group there that has that does kissing bug testing, and they've got a great Chagas page. They've got pictures of kissing bug lookalikes, and so they're a great resource. I'd say that about half the pictures that we get in the vet are not kissing bugs. So that's the first step. Send us a picture. And then if we determine it is a kissing bug or possibly a kissing bug, sometimes it's difficult to tell from the pictures, then the bug can be sent in for testing. And so that testing is done at CDC, and depending upon workload at CDC, turnaround time, it can be anywhere between 3 weeks and 8 weeks. So it can take a bit of time sometimes. But if that bug does test negative, done, Chagas disease is not a concern unless there are other bugs that the person might have been exposed to. And then if the bug tests positive, that's when we want to go to look at process 2 or process 3. And I'll have you go ahead and go to the next slide. Thank you. Okay, so process 2 is serology testing. So as far as bug exposure, it is at that 8-week period of time. So after exposure, that if a person is infected at that point in time, they should have detectable antibodies between about week 6 and 8. And so that is the second thing you see there on the left. This also addresses other situations. A person that tests positive at a blood bank, a person with onset of cardiac disease compatible with chronic Chagas disease, or a person with a Chagas positive mother or sibling, or someone exposed to blood or tissue from an infected person or animal more than 8 weeks prior. So all of these situations are where you would want to use serology testing, looking for antibodies. Our DSHS lab started Chagas testing, Chagas serology testing, I can't remember, 2 or 3 years ago. And they use 2 tests that detect antibodies to different antigens. And so this is a really great option. Unfortunately, a lot of providers use a specific lab to draw blood, and then they test, with that lab. So not all providers are set up to use the DSHS lab, but it is a great option because of those 2 tests being used. Another option, which most providers use, is using a commercial lab. And I will share you a list in a moment. The page 2 of this document is a list of laboratories. And so this basically tells you, okay, so if you test negative at the DSHS lab or commercial lab, then you're negative. Person does not have Chagas disease. If there is positive serology at the DSHS lab, they only call the result positive if the person tests positive with both of the EIAs that they run, both tests. So if there's positive serology at that lab or a commercial lab that utilizes 2 or more tests that detect antibodies to different antigens, then those results indicate the presence of antibodies to T. cruzi. So that person is considered to be positive for T. cruzi. And then we have, a CDC link that has information on Chagas disease evaluation and treatment. If the person is negative, the person does not have Chagas disease. If the person tests inconclusive, that's another story. And inconclusive serology, I would also consider if there's a single positive diagnostic screening test, that should also not be considered positive because it is a single test and you cannot rely on a single test for diagnosis. And I will cover that a little bit more when I get to the list of labs. Next slide, please. Process 3 has to do when PCR or a blood smear is appropriate. So this is a situation where a person was exposed to a positive kissing bug, or, potentially exposed less than 8 weeks prior. Typically, our guidance is to wait until that 8-week mark and have serology, but sometimes people are very worried, or the person that was exposed has some symptoms that may be indicative of acute disease. And so we do recommend that there is consultation, or we always recommend consultation with zoonosis control staff, not just, sending a sample directly for PCR testing. Second situation where this would be appropriate is where a person traveled to a highly Chagas endemic area and has acute symptoms. And then, of course, also that exposure to blood or tissue from an infected person or animal. So PCR is a great test. Blood smear is a test that is available at our lab, and most commercial labs will offer a blood smear exam test. However, the blood smear exam I've heard that it's sort of like finding, a needle in a haystack, because you may only have a few parasites. And whenever that you're looking at that blood smear, there may be so few that you don't necessarily see it in the blood smear. And so it's confirmatory, but not a very sensitive test, but it's an option. It's a great option. And CDC does need to agree to testing by PCR. CDC does offer PCR testing, but as Sue mentioned, it is currently offline. We hope to have it online soon. But CDC, Sue, is still the one that needs to approve CDC testing. So there is a lot of communication between our regional health department, us at central office, our lab, Sue, with all of these situations, really. I mean, Sue gets emailed all the time about things happening in Texas, you know, from, hey, you know, my patient was exposed to this bug to, you know, and so constant communication. And again, it just takes you back to this, if a person tests positive, and then it has the CDC link. Negative, the person does not have Chagas disease. One thing I have not addressed here in this testing guidance is metagenomic sequencing. There is a lab that offers some really high, you know, high-tech testing that it's not specific for Chagas disease. It basically is testing, looking for non-human DNA, so pathogen DNA. And this test is actually what allowed for the diagnosis of 2 of our acute cases. Additional testing was done, which confirmed that it was definitely Chagas disease, but this testing is becoming more and more common. Next slide, please. And this is the list of labs that perform T-Cruzi testing. I have since learned of some additional labs, so this is not a complete list, but I did want to explain the difference here. So the Texas Department of State Health Services lab, as I mentioned before, it runs 2 different tests. It runs the hemogen and Wiener ELISAs. And so if you get a positive result here, it means both tests were positive, and therefore that is diagnostic. That is considered positive. The next 3 labs that I have listed, they will report out with a single EIA, a reactive or positive result. And that's really a screening. It's a positive screening test because you don't have 2 different ELISAs. So you need an additional test to confirm. The next lab listed there, Kefra Diagnostics, they actually have 3 tests. And so they run an ELISA and a TESA. And then if those test results are discordant, they have another test that they can test with. And so if 2 of those 3 tests are positive, then they would report out as positive, is my understanding. And so that was what I was talking about before. If you have just a single reactive ELISA, you're not done. You need more testing. And then, of course, CDC, as mentioned, currently offline. However, with CDC approval, PCR samples can be routed through our lab for Texas residents for testing at the Wadsworth Center Parasitology Lab, and that is free of charge. And next slide, please. And lastly, and by the way, I wanted to mention, while we're on this slide, we had a regional veterinarian years ago that was really passionate about Chagas disease, and he would go out and collect these bugs all the time around his house. He actually sent in several bugs found inside his house, and so he provided me with a lot of these pictures I'm using in this presentation. Next slide, please. All right, challenges. So a lot of this is reiteration of what I've already mentioned. A lot of bugs look like kissing bugs. So very common. The kissing bug turnaround time can be quite long. A lot of these people exposed to these bugs are quite anxious, and they are waiting on these results so that they can determine whether they need testing. And a lot of these people, they think that at week 8 that it's too late. And so there's a lot of anxiety regarding, am I going to get my results in time to be treated before it's too late? And of course, we've discussed the lack of provider awareness in the United States for Chagas testing, for chronic disease diagnosis. You know, it's very very complicated. There is the issue that it takes 2 or more tests in order to accurately diagnose. With commercial lab testing, the most common lab that is used in Texas, we see a very high rate of false positives. That's a very sensitive test. And so if that is used as a screening test, it results in a lot of follow-up testing. It is often difficult to get follow-up testing for individuals testing positive with blood donor screening and or commercial lab testing. That is one reason we have Chagas disease reportable is because we see a lot of people screen positive whenever they donate blood. And so what happens is, those results come to us. We send it to the appropriate investigator, and then they try to make contact with the individual and testing recommendations. And sometimes it's difficult to actually get those individuals to communicate with public health and to get any of that follow-up testing done. And then, of course, public health reporting. The case definition has always been a bit challenging and complex simply because the testing is complicated and a lot of different steps, at least for chronic disease. And then also it's difficult to ascertain where disease is actually acquired for those chronic cases. I mean, you don't even know how long some of these people were infected whenever they're diagnosed. And I believe that was my last slide. Yep, thank you.
Awesome. Thank you so much, Bonnie. That was really informative. And I think for all of you watching, whether you're in the Southern US or not, I love your algorithms, Bonnie, that you have created. I know a lot of painstaking time and detail has gone into those. And as Bonnie said on the website for DSHS, you can find these. And thank you for also sharing the data. I think it kind of helps lend perspective on how, whether you're in a local transmission area or not, like how the bugs work and what other people, maybe if they're coming from Central America or Mexico or South America, also sort of encounter, in terms of the different types of bugs. And also thanks for mentioning Dr. Wozniak. I always miss his enthusiasm. He's on sometimes on these calls, and he's always great to have. But so we're kind of running low on time, and I want to give Aisling from LA County Health Department some time to present. And so how about if you have any questions for Bonnie, if you wouldn't mind putting them in the chat, and then if we have time, when Aisling's done, we'll also open it back up. But thank you, Bonnie, so much. This was really, really good. A lot of great information. And it's evident how much work you put into this. So thank you. All right, Aisling, are you?
Yes, so I was just trying to see if I could actually see my notes as well, but I can't. So I wonder if you could share at your end. Sorry to put you on the spot.
That's okay. Kata, do you have access to the slides?
Yes.
If you wouldn't mind, and then we'll just
Thanks very
advance
much.
for her.
Wonderful. Okay. Hi, everyone. My name is Dr. Aisling Vaughan, and I am coming to you from Los Angeles County. So we'll proceed to the next slide. Thank you. And apologies for the croaky voice, but a winter bug. So as you've heard from the previous two speakers, Sue and Bonnie, Chagas disease, it's a vector-borne disease. If you could just click on, please, thank you. Caused by the parasite Trypanosoma cruzi and spread by the vector shown to the right here, Triatoma, also known aptly as the kissing bug. So next slide, please. So this disease, it's mainly found endemic areas of 21 continental Latin American countries. About click again, thank you. About 6 to 7 million people globally are estimated to have this parasite, and many of whom don't actually know that they're infected. Next slide, please. And if you click, yeah, thank you. So cases are increasingly observed in other countries around the world due to the movement of people. And as you mentioned, it's estimated that approximately between 300 and 400,000 people have T. cruzi in the US, and this is based on the prevalence in their countries of birth. And if you click on twice more, please. So California has one of the highest burdens of Chagas disease in the US, and it's estimated that around 70,000 people in the state are infected. And almost half of these are estimated to be in LA, with an estimated 30,000 people infected in this county alone. And that's based on seroprevalence study of Latin American immigrants. So next slide, please. So most cases of domestic Chagas disease are from chronic infection of Latin American immigrants, and the high burden of disease in this population compounds the already existing health inequities faced by these individuals. So as Sue mentioned, this Chagas disease is currently reportable in 7 states. Next slide, please. And 2 local jurisdictions, both in California, and I'm going to tell you a bit more about LA County. Next slide, please. So surveillance for Chagas disease in LA County was first initiated in December of 2019. And having seen how successful surveillance has been to reduce the prevalence in Latin American countries, and how it was successfully implemented in other states across the US, we decided here to implement our own. And it was initiated for many of the same reasons that Bonnie detailed for Texas. And in LA, the prevalence of Chagas disease is very high, likely high, based on the county's large population of Latin American immigrants. And also we have local vector-borne transmission documented here too. And the justification, sorry, if you just go back, the justification was that implementation of a surveillance program would help our understanding of the epidemiology of Chagas disease in LA County, which then can of course be used for programming around Chagas disease, implementation of public health measures to reduce the morbidity and mortality associated with the disease. Importantly, it also provides a really important opportunity to link members of an underserved community to medical care. And that's really one of the major focuses of our work in LA County, has been ensuring that people who test positive are linked to care, reducing ultimately the morbidity and mortality associated with Chagas disease, really reduce those severe health outcomes, and which will also have a huge financial benefit as well, to reduce the burden on the health system too. So next slide, please. And you can click again. All the way through, thank you. So LA County, it's a very large county with almost 10 million residents and a very large population of Latin American people. A large amount of the population, proportion of the population, are Latin American. So as I mentioned, serological studies have shown high prevalence of T. cruzi antibodies in the Latin American immigrant population, suggesting there could be over or around 30,000 individuals infected with this parasite. We've also had local transmission documented. It's likely underreported. We do have the vector here. And we actually do have a high prevalence of T. cruzi in the trichomonas in LA County, as high as 36% actually. So it's estimated that 40,000 women of childbearing age are living in the US have chronic Chagas disease. And the US mother to infant transmission rate is estimated to be between 1 and 5%. So according to our calculations, approximately 7 to 14 babies are born with congenital Chagas in LA County, and many of whom remain undiagnosed. And treatment in infancy, it's very successful. It can result in a cure. But on the other hand, if left untreated, between 20 and 40% of infants later with Chagas disease later develop potentially fatal cardiac and gastrointestinal manifestations down the line. So there's currently limited testing for Chagas in pregnancy in LA County, and it's a really underappreciated concern for local providers. So next screen, please. Slide. And you can click through. So Chagas disease surveillance, the surveillance system has multiple sources of data. A few key ones are shown here. So we largely get cases, chronic cases reported to us. So people who have had potentially lifelong Chagas, T. cruzi infection that has then become symptomatic later in life, and the individuals present for care. We also have many cases reported to us through blood donor screening. This is a national screening. We can also have cases from organ donation, and we do also have vector surveillance here in LA County. So you can click onto the next slide, please. And this is very similar to the Texas flow diagram. It's quite tiny. I don't expect you to read every single thing here, but I'll go through again, like in Texas, to the various key points. If you just go one more slide, please. So we have the triatoma toluene kissing bug testing here. So an individual without risk of a bite from a kissing bug, so no evidence of bugs, the bug has been found outside the home, but would like to pursue testing. This is just on the far left. We can arrange testing through Texas A&M University. Somebody then who has had a risk of a bite, so and the bug has been found in the home, we can arrange testing through the CDC in a similar manner. So we request that pictures are sent through to us, including details of when the date the bug was collected, etc. And then we can link up with CDC and ensure that bug is tested. If the results are positive, we may consider human testing, and this is something that we will discuss then with CDC. In terms of human testing, then on the right, so we also have these three categories. So if somebody has a probable exposure to a kissing bug, they're resident or travel to a country where Chagas is endemic, or they're exposed to blood or tissue from an infected person, we would then recommend testing. And that testing, again, very similar, does depend on the time from exposure. If it's under 8 weeks, the individual can get blood smear testing or PCR testing at the CDC. If it's over 8 weeks, we perform serology testing with 2 different antigen tests being a confirmatory test. In the middle, if somebody has clinical symptoms, again, testing depends on the exact symptoms. If they have acute symptoms, they can be tested with blood smear or PCR. And chronic symptoms, we would recommend serological testing. Same for individuals who have tested positive during blood donation, or have a family member or like a mother or sibling with Chagas disease. We would then recommend serology testing. Next slide, please. again, a little small, but if we have a positive commercial test or equivocal test, we would recommend that this is sent to CDC for confirmatory testing. And we don't have local capacity for testing, so all samples are sent to CDC via our public health laboratory. And if the results return positive, this individual has Chagas disease. And we recommend consulting with CDC as needed for clinical management and treatment. If the results are equivocal, we then work with the individual to send a second specimen and return that back to testing to CDC. If the results are negative, the person does not have Chagas disease. And this flow diagram will soon be available on the LAC Department of Public Health website without the yellow box on the left, but that's really just to show the actions at the acute communicable disease control team level. So there is quite a lot of interaction really with the patient themselves, the providers, the testing, commercial testing laboratories, and the CDC in order to get a confirmatory diagnosis through, and of course, report this out as a case. One thing we have noticed, and I'll go into a bit more detail later with the challenges, is how difficult it is, as Bonnie said, to ensure that somebody, let's say a blood donor who receives a positive test, actually gets the opportunity for further testing, confirmatory testing, and then down the line the treatment they need to prevent any really serious complications with this disease. So next slide, please. I'm just going to give you an overview of the cases that we have had in LA County. So between its inception or implementation in 2019 through to December 23, we've had 268 cases. Of these, 67% are confirmed and almost a third non-confirmed. All cases that we've seen have been chronic, and the median age at initial positive test was 55 years, but a range from 17 years old to 88. 78% reported having been born in a Chagas endemic country. 68% were symptomatic at the time. That's how it came to our attention. With symptoms including dilated cardiomyopathy, megacolon and/or megaesophagus, another serious complication from this disease. We were able to reach and interview 63% of cases for exposure information, and that's a really key point in time where we're able to coordinate with them to go to their provider and get further testing if needed, and ensure they're getting the right treatment. We would ensure that they're linked up to clinical centers that could treat them. And in this time, 16 individuals have died with or due to Chagas disease. Next slide, please. So approximately half of our individuals reported triatomine exposure, 12 within LA County. We've had 2 confirmed and 4 non-confirmed cases reporting or denying travel at all. So potentially have been bitten in the area. 64 non-confirmed cases still had not received confirmatory testing, so a median duration delay really of 24 months. And a third of individuals received treatment. And importantly, about half of the female cases had children not screened for Chagas disease, which is really an area that we need to work on, ensuring that those family members' children have been tested if their mother was positive. Next slide, please. I'm aware of the time, so I'll speed up. could you click one more time? There's a box missing. Perfect. So as it's been some time now, we conducted an evaluation to assess the performance of the surveillance system in its first years. This was done just late in 2024. First of all, conducting a literature review, reviewing the surveillance system data, interviewing partners, a number of whom are on the call today, and then formulating next steps. Next slide, please. And you can click all the way through. Thank you. So the evaluation identified a number of challenges in LA County for surveillance for Chagas disease. First of all, it's one of the challenges is, the inherently complex nature of this chronic disease, the complicated testing algorithms, and the need for confirmatory testing with different tests at the CDC, because no one test is sufficiently of high sensitivity or specificity to enable it to be used alone. Complex testing delays, complex case definitions, as well as the need for significant follow-up by public health personnel at the Department of Public Health. And provider awareness. Many of our cases, as I just mentioned, did not have children screened for Chagas as well, which is recommended guidance pointed to a lack of knowledge about maternal child transmission risk. Next slide, please. And it is my last, if you just click the way through. So a number of ways that we can improve surveillance for Chagas disease, not just in LA, but across the country. One is to improve provider awareness of Chagas disease, the importance of early detection and reporting via education and training workshops such as this. Improve targeted screening of at-risk individuals, including those with a history of residing or visiting an endemic country, pregnant mothers and their infants, and individuals exposed to the kissing bugs. Delivering public health awareness campaigns to disseminate information, engage affected communities with the aim to increase awareness, increase testing, and then ensuring prompt treatment for those who need it. Enhancing surveillance system infrastructure by enhancing automatic importation of data, etc. Establishing routine reporting for stakeholders, including quarterly or yearly reports and publication of disease-specific web pages on our website. And then importantly, fostering partnerships with other local jurisdictions, states and national partners to align strategies and share best practices. Next slide, please. And I'll just say that this is not possible without huge collaboration and our great team in Department of Public Health and the Acute Communicable Disease Control Program, Vector Control, our Public Health Lab, and of course our collaborations with CDC and other stakeholders in LA, California, and nationally. Thank you.
Great, thank you, Aisling. I really appreciate you sharing your perspective. For those of you who may not know, it's in California, it is not a reportable disease for the whole state. However, we've had really fortunate, I guess, work being done in LA County first, and then leading the way San Diego, where I'm at right now, having it now be reportable. It just happened last April. I think they did that, launched it on World Chagas Day, which is April 14th. So that was really great. And we're still working out the kinks on what this looks like. And so thanks to LA County for sharing what it looks like there. Other states may not do like local health departments, like Texas, it's reportable throughout the whole state. And they have a different infrastructure. So it really kind of just depends on where you are and what happens. But in California, our local health departments are able to make certain diseases reportable at a local level. So I know we're at time, and this was a lot of information. We again ask if you wouldn't mind please filling out the evaluation, letting us know if you have any other thoughts. And also for your CME or CNE credits, once you fill out that evaluation, it takes a few weeks, but we'll get that to you. And then I think, this was, again, a very broad perspective of reporting. And I just kind of to summarize or to wrap things up, I think that, making Chagas disease reportable, as Dr. Montgomery said, is sort of dependent on what the needs are, where you are. I think that as more people become aware of the disease and more people realize that there is chance for local transmission, there's also having larger populations of immigrant populations maybe in their community, it becomes more necessary to track these diseases. And so my hope is always that more people learn about this disease and it does become reportable in more places. That way we can track it better and understand the prevalence, because right now we just don't fully understand the prevalence of this disease in the United States. And so I think we're going to spend the next many years trying to still kind of figure that out. And so with that, I know we're right at time. I'm going to just ask if there's any last questions. You can also reach out to us. I think I shared the chagasUS at gmail.com is an email that I will answer generally if you have any questions that I can help navigate you towards resources. But also any of our speakers today would probably be happy to help answer any questions that you might have about Chagas disease testing. And again, we do have our next sessions, one a month for the next 3 months after this, so February, March, and April. And I wanted to thank CDN again for their participation with us on this, and also UT Health. I have a fantastic team that helps all the time to get this. They're a super hub for echo sessions, so Kato and Shreya, Karen, thank you so much. And with that, we can stick around for a few more minutes for questions if you have any. But other than that, we hope to see you next month. And feel free to reach out if you have any additional questions at all. Thank you.